Now please join me in welcoming Dr. Jay Bowman.
Good evening. This is fantastic. It's great to see all the names popping up here on the computer. There's a lot of folks that I know. Obviously, there's many more that I don't know, but there are people from all over the world, and it's nice to have a lot of friends here tonight, folks from Romania and Brazil and Canada and all across the United States. So I thank you for taking a few minutes to kind of listen to me tonight about a few things that I'm passionate about as far as clear aligner treatments. So we'll get started here. Certainly the advent of using a series of clear aligners, specifically with the introduction of the Invisalign product, came at the turn of the 21st century. And this is despite the fact that the basis for the concept actually originated over 55 years earlier with Dr. Harold D. Kessling. He published his concept of using a series of tooth positioners to move teeth. And building upon that, Invisalign took that to the next level by using the computers to predict tooth movement and generating that series of aligners. In trying to make the system more predictable or efficient for my own practice, I came up with a few inventions or concepts for myself, and thankfully they've been produced. And one of the things that we're going to talk about tonight is the Clear Collection from Hu-Friedy. So Harold D. Kessling was a real innovator in orthodontics. He's the one that came up with the idea of a tooth positioner, which is a custom mouthguard device used to help move teeth into final positions. He wrote a paper in 1945, discussing a sequence of positioners to move teeth, and that is the basis for what we do today in using clear aligners in orthodontic treatment. Coincidentally, as an orthodontic resident at St. Louis University, Harold Kessling's son, Dr. Peter Kessling, was one of our professors. So we were all well aware of this idea of moving teeth with a sequence of retainers prior to the commercialization of that concept. So there are certainly a number of different companies that have entered this market and many more around the world as alternatives to Invisalign. I'm going to primarily show, in fact, I'm going to only show cases treated with Invisalign in my particular presentation. We're describing the use of clear aligners, also sometimes called invisible braces, but let's differentiate that between the use of a tooth-colored ceramic bracket or lingual braces. Although the original fanfare for plastic aligners that they would replace metal braces, it tarnished somewhat as the early adopters of this system became acutely aware of limitations of the concept. There's quite a bit more to this than just ordering plastic trays. So some orthodontists, they vacated the idea from the beginning, some vacillated on the fence, and others like me simply dug in, and we doggedly invented ways to make this innovation work for our patients. So it's quite obvious more than 15 years later that many patients really desire braceless correction of their smiles. So there's an interest and there's certainly a demand. For example, when searching the internet or browsing the pages of celebrity magazines, you can find pictures of all kinds of celebrities like Zac Efron or Gisele Bündchen, Jessica Biel, Khloe Kardashian, Eva Longoria, Coco Jones, Oprah, Katherine Heigl, Heidi Klum, and even the Biebs, Justin Bieber, have been caught with plastic aligners in their mouth. You can even find a picture of Ashton Kutcher at an NBA game with a collection of cases for his Invisalign sitting in front of him as he's eating a hot dog. As a result of the demand, as I said, there have been lots of different alternatives that have been marketed around the world. But not all orthodontists choose to use clear aligners. In 2014, the Journal of Clinical Orthodontics in their practice survey found that only about 48% of active cases are treated with clear aligners in an orthodontic practice. I'm just wondering how many of you actually are participating or using aligners, and we saw in the original questionnaire that the majority of the folks that are attending this seminar do not use clear aligners, and there might be some reasons for that. Why is it that many orthodontists have not embraced clear aligners? Well, published research has indicated that aligners are very effective for basic alignment, dental intrusion, and molar distalization. but not so much for dental extrusion or torquing of anterior teeth. Now, those different types of tooth movement have certainly been addressed in the last few years in improving the predictability of those movements. But specifically, researchers at the University of Florida reported that only 57% of programmed tooth movement was actually achieved. Similarly, workers at the University of Illinois found only 41% accuracy of prescribed to actual tooth movement. That's a bit disconcerting. So I'd like to quote the lovely actress I mentioned earlier, Katherine Heigl, who was treated with Invisalign, and she said, "I like predictability because I know what I'm getting into." Me too, Katherine. In other words, improving the predictability of clear aligner treatment is a very worthy goal, and has given rise to a number of additional techniques and auxiliaries to make that happen. As this systematic review states in their conclusions, clear aligner treatment is not just dispensing plastic to patients and expecting it to all work out. It requires the use of auxiliaries, attachments, elastics, IPR, and altering the aligners. So what's innovation? It's a new idea, device, or method, or the act or process of introducing new ideas, devices, or methods. And there are certainly things that have been introduced into the use of clear aligners. One of the things that I came up with in the past was the use of aligner chewies, which we'll discuss a little bit more. And so these are some of the things that I came up with to help improve the process of Invisalign for me. This basically is a cotton roll made of plastic to use sort of like an individual tooth positioner in trying to seat trays. These chewies are held between specific teeth that aren't following along the tracking of the trays. They're held for about 10 to 15 seconds, and the process is repeated for 5 minutes, 2 to 3 times a day, especially when changing each new pair of aligner trays. So each of our patients are given aligner chewies to use to help the seat trays during the process of treatment, especially the first few days. As I said, it's kind of a mini positioner. Here's a patient where a canine is not tracking in the aligner. This is one of the original prototype chewies several years ago. Patient is asked to chew in that specific location, and in this particular situation, it certainly worked out. The tooth began to track and followed along with the treatment that's prescribed. I wish it was all as simple as that, but there are other factors in the diagnosis and treatment planning of teeth that are crowded out. We'll discuss some of that as we go along. So we introduced this collection of instruments I'm going to discuss. Coincidentally, at the same time this was published along with a mention about OrthoExcel or Excelident, and I've been involved in some clinical research with that particular device in use with braces and with Invisalign. So again, innovation is taking two things that already exist and putting them together in a new way. So we're using plastic, but we're still thinking like orthodontists and considering the use of pliers to adjust that plastic. So as clear aligners have evolved and progressed in the last 15 years, we've certainly changed the types of cases that we can treat, and we've become more sophisticated in their treatment. In fact, there are many practitioners that are good friends that only use Invisalign and instead of braces, but that's not the majority of practitioners out there. So I'd like to help you increase the utility of aligner treatments and expand the scope of appropriate applications. So we're just kind of wondering if you actually modify your aligner's chair side. So we'd like you to answer this little poll, and we'll see what you do. Obviously, this is for folks that actually do clear aligner treatment to answer. It certainly appears that the majority of folks rarely will adjust the aligners chair side. So with that in mind, we're going to describe some instruments that I came up with that I was fortunate enough to have Hu-Friedy decide to fabricate. I was happy when I got the prototypes because I got what I wanted for my own practice. So it's all just icing on the cake when they decided to offer them to the public as well. The first instrument is called the teardrop. And the teardrop is a device to add hooks, elastic hooks on aligners anywhere, anytime, any place. And the design of the hook is a little bit different as well. We know some of the aligner companies, especially Invisalign, do offer precision cuts to provide for these types of hooks. What I'm looking for is the ability to add and subtract these whenever, wherever I need them. And certainly I can prescribe them with Invisalign, but there are occasions where I might forget or I might want to add them during a series of aligners, and I can add them anywhere I want along the plastic trays and even on the lingual surfaces or in locations where they're not typically prescribed. This is a very simple way of creating this hook. You just squeeze the plier and you're going to produce basically a hole punch in a teardrop shape. And the point of the teardrop is that I want the elastic to be hooked into the plastic so that when the patient is inserting the aligners, that they will actually take the rubber bands, hook them into the teardrop hooks, and then seat the trays with the elastics in place. They're not trying to fumble with the elastics on those hooks when they're seating the aligners. And I oftentimes will use buttons, which we'll see, that are bonded to the teeth, so they'll go from a hook to a button. So it's a reservoir to hold the elastic in the tray and to try to make this an easier process because we're very dependent on patient compliance, and not only wearing the trays but also the elastics. So we'll angle this teardrop to produce the hook that we want in whatever location. Like in this particular instance, it's in an upper canine for perhaps either class 1 intramaxillary or class 2 intermaxillary elastic application. So it's an elastic reservoir that the rubber band is already connected to when you seat the trays. This is a precision cut, an Invisalign provided notch, which many of us prescribe. It's a little larger than the teardrop cut, and typically the elastics are not going to just hold on to that tray as you seat the trays. And when we're doing something more sophisticated, like in this particular instance where we're producing a class 1 intramaxillary force from a mini screw in that upper arch, plus a class 2 elastic, we'd like to have those rubber bands hooked into the tray and making it a little easier for the patients to connect the rubber bands to those buttons and or mini screws. This is a little article that one of the major Invisalign providers, Barry Glaser, wrote, and he's talking about using class 2 elastics as an everyday part of treatment, which has really become pretty standard for patients that are class 2s or you're concerned about increasing overjet. I prefer using bonded buttons on the molars and sometimes even on the canines, and we're going to show that in a minute. He's using hooks cut into the molar area using either the Invisalign prescription or maybe with some sort of a notching tool. And I find that lifts the trays off the posterior. I'd rather go right to the tooth through a bonded button. Here's a patient, 13 years old, class 2 on the right side, and a deep overbite and some crowding. And we'd like to correct the class 2 on that right side using Invisalign, some molar distalization supported with class 2 elastics. So we've used the teardrop to produce a notch at the canine for the Invisalign that she's wearing. We also are doing the same thing on the left side. And we have buttons bonded on the lower first molars, and we're going to cut out an area where those buttons can fit into the plastic. And we have a plier for that. Invisalign also provides for precision cuts in some instances. And this shows the overcorrection of the class 1 relationship in that right side and the reduction in overbite and the crowding, and a little bit of overcorrection in the midline. So the teardrop-shaped hooks that we create with this particular plier are usually cut at an angle to resist the line of force of the elastics that are being employed. And they can be added anywhere that you want them along the aligners. We typically may use a series of these if we're using different types of elastics from class 2s to 3s to intermaxillary elastics such as delta or triangle elastics. And this is the way that it used to be done in many practices. You would use these old school custom notch cutting tools. Some people dispensed them to the patients, or they were used in office, not particularly the most professional method of cutting notches in plastic. The elastic hook is sometimes not allowed by some of the manufacturers in certain locations, and they always have the caveat that you may be compromising the contact with an attachment in that particular location. So again, use these at your own risk and realize that you could be compromising the effectiveness of the attachment in that area, but the trade-off is, of course, you need the elastic support. This is a patient treated several years ago. She was really reticent to do any type of orthodontic work, especially with Invisalign, and we had asked that we remove an upper bicuspid on the right-hand side to resolve the severity of crowding in her case. She started with just aligners in the lower and gained her confidence and then permitted us to actually treat the upper. So she has severe crowding and a deep overbite. We need to retract the maxillary canine posteriorly after extracting the upper first bicuspid. And in this instance, we've got a mini screw between the upper first molar and second bicuspid. So we're going to use intramaxillary class 1 elastics. In other words, it's sort of like a unilateral headgear force. So she's going to hook a rubber band to the Invisalign tray, mesial to her canine, and that elastic will be stretched back to the mini screw. So we retracted the canine into position, resolved the crowding. The hole punch plier, which we'll show you soon, we used on the lingual because we added buttons on the lingual to assist in counter-rotating the effects of the retraction forces. So in these instances, the Invisalign trays are kind of working as a guide, and the force is coming from the elastic. In this instance, we've got a patient with a silver filling that is unfortunately not aesthetic in this region after closing the space, and that will be replaced in the future by her family dentist. So this is the initiation of her treatment and the completion of treatment a bit after the time she's been in retention. So only at this time, I'm aware that Invisalign manufactures aligners with notches and hole cuts to add to elastics, but I believe that in the past it was only on certain teeth and not on the lingual. That has been changing, and we just are prepared with these instruments to provide anything that may not be provided by the manufacturers, or in some instances the manufacturer may have forgotten that they need to place some of those cuts. So we're prepared for any eventuality for that. The hole punch is the second pliers in this series. It's a device that's basically just a hole punch, and it relieves plastic to add in bonded buttons for the use of elastics or even elastic chain in some instances. And we can also use it to relieve plastic that is impinging in soft tissue. And that could be done anywhere along the liner. Sometimes we find interproximal areas where the aligner is impinging in the papilla. Other times the aligner margins are a little bit long and into the soft tissue. So we can just nip away plastic in those regions as well. And again, these were the old school custom hole punching tools. And we've modified that for use with the clear aligners, specifically for adding in what I call a half moon cut into the plastic. That's clearance for buttons. Like in this instance, we've got intermaxillary rectangular box elastics or seating elastics, oftentimes used with braces, but also with aligners to seat them. And we are using the hole punch with a series of buttons and elastics to help seat lagging teeth into the aligners and actually improve the occlusion at the end of treatment. So here's the patient with rotated and uneven upper lateral incisors. Those teeth are notoriously difficult to correct with clear aligners. We've all experienced this with any of us that have used clear aligners. They're a frustration, and correcting these requires more than just putting some buttons or elastics in. It requires a real accurate diagnosis and treatment planning as to how we're going to get these teeth to move. First of all, they're crowded. If you expect them to move at all without creating space first, it's just not going to happen. So this unpredictability is partly our own fault. So this patient has lost tracking. There's lag for the upper left lateral specifically. We used a hole punch on the lingual of that lateral to produce a site for a button to be placed. and clearance for that button. And also on the lower, on the buccal surface or facial surface, also the hole punch was used. And the elastic was used through the bite to seat that lateral incisor into the aligner, but ultimately to even it with the other incisors and produce an aesthetic result. We also had class 2 elastics in that process, also using buttons and teardrop hooks, and so it was a combination of class 2 correction and extrusion of the upper left lateral incisor. The strategy for unpredictable extrusive movements. You have to plan from the first stage what you're going to do. Currently, what I've been using is I ask in the setup for the lateral incisor to be put in its final position where I desire it to be at stage 1, and I place the buttons and hooks and elastics from stage 1, so there's a large gap from where that tooth is going to go to where it is now. I don't want to deal with unpredictable movements. I want to move that tooth down into place quickly. Class 2 elastics, or making skeletal changes with aligners, is possible to some degree, including some molar distalization. And in these instances, we can use a combination of teardrop cuts or hole punches with buttons, and we can use them in class 2s or 3s or even in delta or triangle type elastic situations. So the hookup here for this patient who has a mild class 2 relationship, some maxillary spacing that we want to retract, we've got a combination of class 2 elastics and class 1 intramaxillary forces coming from mini screws. So we're pulling a vector nearly straight posteriorly to close those spaces and help to keep the molars class 1, canines class 1. Also, patients can present with soft tissue impingement. In this case, the incisive papilla is mildly inflamed, but the patient's feeling some pinching pain there. So we simply clear the plastic using the hole punch to relieve the impingement of those soft tissues in that series of aligners. Remember, just cutting one aligner is no good. You've got to go through the series of aligners in order to relieve this for the patient. So this can be used anywhere along the aligners where plastic is impinging the tissue, kind of almost like a bone rongeur. So you're kind of just pinching away plastic where there is impingement. I find this easier to work with than using even crown scissors. Clinically, what this looks like is, let's say we're going to dispense a series of 6 aligners or more for a patient. These tray setups are put together for whoever is going to process that series of aligners, meaning that they're going to, perhaps in this case, do that hole punch at the incisive papilla. And these are prepared in advance of the patient showing up. And we'll show more of that in a second. Aligner lag or lost tracking is the most often characterized as an air gap between the incisal or occlusal edge of teeth and the plastic. It indicates that the teeth are not following the prescribed tooth movement. And it's easy for you to explain to patients. If you start to see an air gap, we either need to slow down, you're not wearing the aligners enough, and we need to have you wear them at a longer period of time till the air gap disappears, or you may use aligner chewies, or you may add in these elastics we're discussing. But remember, part of this is still the problem of the orthodontist actually treatment planning, creation of space prior to attempting to move these teeth. So if we're trying to reduce air gaps or reduce tracking error, we may use what I call bootstrap mechanics. It's actually been coined, that term's been coined prior to my introduction of it here. In this instance, we have 2 teardrops that have been cut adjacent to each side of the canine, and that elastic is hooked in there. And around to the lingual surface, we'll have a bonded button where we've used the hole punch to clear the area for that button. So the elastic is stretched across the occlusal of the aligners. So it's fairly innocuous, especially with clear rubber bands or elastics. Patient places their trays, the elastic's already hooked into the tray, and they just have to connect the other part on the lingual surface. There are other ways of doing this. You could also use buttons on both sides of the tooth, which we'll show in a second. So the bootstrap mechanics forcibly erupt a lagging tooth using elastics. And the hole punch provides the clearance for the buttons, or teardrop is also used to cut nachos in the mesial distal embrasures of the plastic. And that rubber band is just stretched from one button to the teardrop or to another button on the opposite side of the tooth. So the bootstrap mechanics are a very useful way to eliminate lag, especially in a specific site. As I said, we commonly do this in sites where lateral incisors we feel are going to have a problem tracking. This is just, again, the same idea so you can get an idea what it looks like all hooked up. This is a patient with a problem with tracking lateral incisors. We've cut 2 teardrops on each of the laterals on the buccal surface in the embrasure spaces. On the lingual, we have buttons. We've used the hole punch for those buttons, and the elastic is just stretched over the occlusal to drag those teeth into the aligners. Once again, we can see the lag that's occurred here at the incisal edge. We now have a tooth-colored button at the gingival margin of the lateral incisor, and we're stretching across the occlusal surface to a bonded button on the lingual. And you can see those buttons there. The clearance has been provided with the hole punch so that there's room for that tooth to be dragged down into the aligner to seat it down solidly. Now, do you think that these laterals are going to track predictably in a teen patient? Nope. The upper left lateral is off the rails. So we've created the teardrops to button scenario, facial to lingual, to help to reduce the air gap. And we've seated that aligner down into position. So this is before and after the use of Invisalign teen and more predictably moving that maxillary left lateral incisor. This patient has a reverse smile line, an anterior open bite tendency, and crowding. This is a patient, if we added braces on, within a few days we'd have a significant anterior open bite unless we were sequentially bonding and carefully managing the occlusal plane in this particular case. So we chose Invisalign. And we can intrude the posterior teeth. If you've ever heard Willie Dan discuss his method, we have modified that slightly, but I still am a big fan of how he uses aligners in sequentially increasing the overbite. We do have attachments in the anterior. I'm not a big fan of those, but in this type of open bite situation, we do use them. We've added class 3 elastics to assist in keeping a positive overjet and to help keep the bite closed down. We've used hole punch at the upper molars for those buttons, teardrops at the lower canines mesial, so they're class 3 elastics. So we also used, in this instance, these rectangular seating elastics, oftentimes also used with braces. This is hole punch, 4 of them with 4 bonded buttons and elastics to seat these teeth into the trays and ultimately improve the posterior occlusion. So here she is again, age 13 at the start, and her conclusion of treatment. If I were to improve this case, I would have added additional upper posterior buccal root torque. This is a concern that the American Board of Orthodontics has had in the past in cases that failed the ABO exam. It is certainly translatable into Invisalign, especially with the new method of doing ClinChecks. So always look at the posterior, and as we were all told as students, turn the models around, or in this case, turn the virtual models around, and look at that posterior occlusion and check the curve of Wilson and try to improve upon the occlusion that you're seeing here. So this is, again, class 3 elastics, rectangular box elastics with a combination of the Clear Collection pliers, bonded buttons. This patient I just completed treatment a few days ago, class 2 division 2 type patient with significantly rotated lateral incisors and hyper-erupted or over-erupted centrals. Do you think those laterals are going anywhere unless we create space first? Well, we actually even attempted, after creating some space, to use some larger attachments A friend of mine, Jonathan Nicodesis, is one that wrote an article about moving canines and lateral incisors and came up with this kind of configuration for these enlarged attachments. Fortunately, this is after a bit of time, and we still haven't seen any significant improvement. So I'm not willing to wait around. I want to improve the predictability here. So we've got button-to-button bootstrap elastics. So we've cut out with our hole punch a relief for the clear buttons on the buccal and regular metal buttons on the lingual, and she's wearing elastics across the occlusal of the aligners to drag those teeth down into position. So this is a situation where I would treatment plan, creation of space, and then I would ask that the entire movement of that lateral incisor occur in one step. Now, certainly I'm not going to attempt to intrude the centrals in a single step, but I would like to drag down the lateral incisors the majority of the distance that I wish them to be, and let the elastics do that work, and the trays will be the guide. And this is the completion of this particular patient, and she's the subject of an article that I just submitted for publication in Seminars in Orthodontics. It should probably be out later this year, describing improving predictability of clear aligners. This is an adult anterior open bite case, and Invisalign's become quite innovative in coming up with methods to treat open bites, which are notoriously difficult to take care of. There have been some seminars that have been put on by some of the experts from Invisalign, and they all have some subtle differences in their methods of treating this particular problem. I used a modification of Willie Dayan's technique, but again, I'm impatient. I want predictability, so I've added bootstrapping or sling elastics with mini screw support. So in the upper, we have 4 mini screws on the lingual and buccal of those first molars with elastics that are going across the occlusal. And on the lower, I have teardrop notches cut on the lingual of those first molars with the elastics draped over to the mini screws to provide for intrusive forces. So 6 total mini screws, upper sling elastics, teardrop notches on the lingual of the lower molars, and then we went to the box rectangular elastics with hole punches and buttons to seat further the occlusion. This patient's in progress, but we've got a substantial improvement in the anterior open bite. Again, there's not a lot of information on long-term stability versus braces or even surgical correction. Open bites are just tough. But at least we're able to get them closed down using the advantages of clear aligner treatments. The next pliers I want to talk about, the names of these pliers were influenced by a science fiction television program from the 1960s. Some of you may remember The Outer Limits. If not, let me jog your memory a bit, and some of you might be familiar with this opening of each episode. It featured an ominous voice warning the audience that we will control the horizontal, we'll control the vertical. You're about to participate in a great adventure. You're about to experience the awe and mystery which reaches the inner mind to the outer limits. Well, the names of the next 2 instruments in the Hu-Friedy Clear Collection were specifically named as a result of this iconic outer limits introduction. These are the vertical and the horizontal pliers. The intent here is to improve the predictability of specific tooth movements. Rotational movements are oftentimes difficult to achieve, especially if you don't include overcorrection, which is a principle that was derived from the old Begg technique. The idea that you have to move the tooth past where you want it to remain. And I also want to stimulate the orthodontist memory to look back at the Edwards procedure. You look at Edwards' paper in the AJO in 1970. Do not underestimate the importance of the Edwards procedure or supracrustal fibrotomy in helping to maintain some of these difficult rotations, especially in maxillary laterals for Class II Division II patients. So the vertical plier was designed to accentuate rotational control. In effect, to try to overcorrect the rotation, adding a little additional force. So it can also be used secondarily to increase retention of plastic aligners or retainers interproximally. So the vertical is going to produce a small indent that's rectangular in shape at the mesial or distal of a specific tooth. And you can do this on the facial or the lingual aspects of the aligner plastic. And the indentations are made without heating these pliers. It's a very shallow depth indentation, and you don't want to compromise the integrity of the plastic or end up punching through the plastic. This is going to be done through a series of the aligners. So you just basically place the plier where you would like on usually a line angle of the tooth at the mesial or distal, and a soft touch is necessary to add that little accent into the aligner. It's sort of a pressure point in that specific spot. We're not opening up a hole in the back of the aligner. We're just adding that little bit of extra push because we're going to go through a series of aligners. This is different from just putting one retainer in to do minor tooth movement. This is over a series of aligners in time. So do you know the limitations? I mean, it's quoting Clint Eastwood, man's got to know his limitations, as he said in the Dirty Harry movies. So if we understand these limitations as we sort of described them when I began, it's no wonder that innovations have flourished to improve the predictability. So the application of vertical indents during the course of aligners may help to reduce the problems of doing lots and lots of refinements. You may be able to make this small nudge of that tooth and correct that rotation without going through removing attachments and taking PVS impressions or going through scans and waiting for new aligners. The severe crowding here would tell you at the beginning you've got to have created enough space between these teeth by expansion, flaring, or removing teeth or IPR before you could actually get this tooth to move. So in this instance, the vertical plier may not actually produce enough because the space may be insufficient. But if we're working through a series of aligners and the space is still being formed, this certainly may help. So in creating this rotational couple using the vertical plier, we place an indent at the mesial of that central incisor in the lingual surface and also at the distal line angle of the tooth on the buccal surface. Now the horizontal plier is one that will add torque ridges anywhere along the aligners, wherever you'd like to place them. This could be for lingual root torque or labial root torque. It also can increase the retention of aligners or retainers when these indents are placed in undercuts. So it can also be used to increase the retention around an attachment that's been placed on a tooth. Sometimes that connection between the aligner, indentation or molding that goes over that attachment may be insufficient. It's not a sharp enough contact. So if you place a little indent alongside that attachment, either with a vertical plier on mesial or distal to affect rotation, or at the gingival margin of an attachment, will help to increase the retention. Again, no heat's required. You can add torque in a specific tooth. It's a lengthwise force application for tooth, or it's actually root rotation, which is what torque actually is. So we're producing a couple of pressure points to affect that rotational change in the angle of this root. And that can be done in more than just in the anterior region. It's just easier to depict this in a central incisor. It's the same concept as the torque ridges in the Invisalign product itself. And you might have forgotten to place those, so you can add these. Or if you want just a specific tooth somewhere down the line in treatment, now you can simply do this yourself chairside. These indents are also used to increase the retentiveness of the aligners or retainers by placing that indent at an undercut. Now, we got to remember that this isn't for a single aligner. It's a process of a series of aligners. So whatever you're going to do to one aligner, you're going to have to do to a series of them. And clinically, in order to streamline that process, I created a prescription form. That form will accompany the aligners for each particular patient. And it notes the specific sites where you're going to use these instruments and what you're going to use them for, because you might forget, or one of your technicians may be the one who is actually using these pliers. So I have some keys here for a mini screw, a horizontal plier, the hole punch, vertical, teardrop button. So we'll place or draw those specific symbols in the location we're going to apply those types of forces, and we talk about which aligners are going to be modified and the date that this is prescribed and the patient's name. So in preparation for a patient coming into the clinic, the prescription is completed. The orthodontist is going to note what mechanics are being employed for this patient, so we're not confused as to where these particular cuts or indents go. And once all of that information is on the sheet, a copy of this can be included in the patient's chart, scanned into your computerized charting, or can be kept with the aligners that are going to be dispensed to the patient. So particularly in my instance, I come in the morning and there are a series of trays set up for the Invisalign patients for the day, and I will have completed these prescription forms, and I'll have my series of clear collection, pliers, and I will then modify each of these trays. I can have staff members do that. I prefer to do it myself. I get confused enough on my own. I would rather be the one responsible if I put the cut in the wrong location. So this is a way of double checking that the cuts are placed where you want and the mechanics that are going to be set up are what you're desiring for that patient. So the prescription accompanies the aligners to be dispensed along with the necessary pliers, and I go through these series of trays prior to patients arriving for the day, so they're all set up ahead of time. We're getting near the close of the presentation. There are resources for more information on not only the clear collection, but also some of the mechanics I've described tonight. There were a series of 3 articles that we published in the Journal of Clinical Orthodontics at the beginning of 2014. They are available from the JCO with, I believe, a subscription to this excellent journal. I happen to be one of the editors and contributed a lot of articles. I would encourage you to look at those. There are a number of interesting cases provided by orthodontic colleagues from around the world in those articles illustrating what we've sort of touched on this evening. The 2 journals on the top from Orthodontic Practice US is a 2-part series on the clear collection itself, and I believe that downloads of PDF files of those articles are going to be available in just a second for your reference. And in conclusion, I think that these adjuncts that we've introduced from aligner chewies or retainer retrievers and using the clear collection have certainly assisted in allowing us to do more things with clear aligners by adding adjunctive forces from the application of elastics to elastic chain in some instances, elastic thread, using mini screws, etc. So we do a lot of the things that we can do with braces with aligners as long as treatment planned appropriately. It's not enough just to add in the buttons and elastics without properly treatment planning what you're going to do with them ahead of time. Now, I am not able to advance the slide. I will have to see where we are here to get over to that. I may need some assistance from my folks there at Hu-Friedy. If you could advance the slide for me. Okay. The instruments in the clear collection help us to customize the aligner's chair side, and that enhances the desired biomechanics we have, and they streamline the addition of adjunctive forces during that entire course of aligners where you desire those forces. There are videos, instructional videos available on YouTube. If you search Clear Collection, I have them actually on my office, Kalamazoo Orthodontics YouTube site, but Hu-Friedy also has them as well. Would you advance the next?
Dr. Bowman is queuing up the questions. Let me share a few things that you'll need to know regarding CE. The link to the post test will appear on the screen very near to the close of this program, and you will have the option of clicking that link in the web link pod, or you may copy and paste the link from the notes pod in your browser. Upon successful completion of the post test, you may download your CE certificate. If you experience any delay in downloading your certificate, it is most likely related to the high volume of test takers. Additionally, you will receive a follow-up email with the link to print your CE certificate. You'll also notice that there are a variety of resources available to you in the seminar room that will include video clips, articles written by Dr. Bowman, as well as the clear aligner prescription form he shared with you.
Great. I'll answer some of these questions right away. Sandra G. asks, a typical case, how many months of treatment? It varies dramatically from somewhere from 6 months to some to over 2 years. So what type of retention do we use? Again, varies from patient to patient depending on each one's needs. Retention is a lifetime commitment to periodic wear of at least removable retainers, and oftentimes fixed retainers are also used depending on the nature of the original malocclusion. So additional aligners are definitely used. There may be refinements, meaning more than one series of aligners is used for a particular treatment, especially if it's a complex treatment. Melissa C. asks, have you tried intrusion of molars without mini screws, placing elastics that go from buccal to lingual, or elastics make an X on the occlusal surface as an idea? The dilemma is that would seat the aligner to, I'm assuming, buttons on the teeth, but I'm not sure where that's going to connect to produce an intrusive force. Certainly with Willie Dayan's concept, he's using the aligner itself as the intrusive force. I just want to improve the predictability of that with the elastics and the mini screws like I would do with a braces patient. Melissa C. asks, what if it's minor tooth movement, just 1 or 2 trays? That's certainly an option. Usually with minor tooth movement, I was using clear aligners, I'd be looking at something that would take 4 to 6 months, not just 1 or 2 trays. You're probably looking at more than that. You're probably asking for too much movement with just 1 or 2 trays, when typically Invisalign is always prescribed about 1/4 millimeter to 1/2 millimeter per month. Have you tried, all right, we already asked that one, let's see. When a patient has the various adjuncts in place in your experience, do the patients have difficulty removing and replacing them, since with clear aligners you're supposed to take them out when eating? It takes a little bit more time certainly to add in elastics, but if the elastic's already attached to the tray, and we ask patients to change their elastics at least once or twice a day, but preferably whenever they take the trays out, they could put new fresh elastics in. It does take a bit more time, and we're trying to make it as easy as possible to get those elastics back in place. But it's the same time, or the same effort that patients with braces would have in using rubber bands. Do you find an increase in the incidence of incisal caries? Certainly, if a patient is imbibing acidic drinks, acidic candies, or maybe have GERD, reflux, acidic diets, and are not cleaning their aligners after they are drinking those fluids or beverages, then that would certainly be a concern. So we do ask them to remove them and clean out the aligners before they replace them. Can you use these pliers on Vivera retainers? My assumption is yes. I have not used Vivera retainers. I know a lot of my colleagues are fans of them. I don't remember the thickness of Vivera retainers compared to Invisalign, nor the material that's used, but I'm assuming that the answer would be yes. When palatal expansion is needed, can clear aligners be used? To a limit. Not significant palatal expansion. In those particular cases, the same with significant amounts of molar distalization or severe class 2s, you would probably want to use a more typical fixed device for those things, maybe doing a rapid palatal expander or a quad helix prior to expanding or prior to adding in Invisalign. But minor expansion of the arch forms is possible. Do the bootstraps elastics place any unnecessary torque on the teeth with the elastic on the interior of the tray? My assumption is that the force is enough to get the tooth seated, and then you're going to stop using the elastic, and you will have recovered those torquing forces. So yes, I would say you need to be concerned and aware of that. Are TADs or mini screws ideal for elastics wear to correct the bite? Ideal as in they work. It may not be for the most severe cases. You may want to consider using braces and or some type of, as I said, fixed device if it's a severe Class 3 or Class 2. But yes, TADs work great as an elastic hook. What other kinds of clear systems are you currently using or used previously? My experience has been primarily with Invisalign. I've dabbled with a few of the other systems only because I've just wanted to focus on Invisalign itself. I have no vested interest with them. But once you learn a system, it's the same as with braces. If you spend the time to work with the appliance you are with, you've decided to work with, you're going to learn how to make it work right for you. And I see so many people jumping from prescription to prescription, or in this case, I guess it would be a liner system to a liner system, that you never really quite learn how to do the best with the system that you're working with. Take the time. It is technique sensitive for anything that you're doing in orthodontics because it's individualized to the patient. How do you clean aligners? With a toothbrush and water, or denture cleaner, or there are also different denture or Invisalign or clear aligner products out there which are basically like a denture cleaner material. Can elastics be used to rotate a tooth that is not tracking? Absolutely. You could place buttons on two adjacent teeth and attempt to stabilize one and rotate the other. We've done that also with elastic chain. And when we do that, we use the hole punch to clear the plastic out of the way of the elastic chain. Did the aligners ever crack from using teardrop or hole punch? I've not experienced that, but I could certainly understand where that could happen depending on what the material is you're using. With the current material that Invisalign has, I have not had that happen. Have you tried fluoride varnish with aligners? Do you think it's a good idea for braces? I've been using fluoride varnish long before we really had talked about it for use in the United States. I had learned about varnishes used in Europe to help to reduce decalcification, scarring, and I use varnish routinely for our braces patients every 3 months, and I have some articles that have been published on that topic, including some research, and if I'm not mistaken, the guy that's from a friend of mine that's been involved in a lot of that research, Adilson Ramos from Maringá, Brazil, is on this presentation, and he would be an excellent, in fact, he's the one that asked the question. Thanks, Adilson. I have not used it with aligners, but I certainly think that would be a good idea, and we should talk about that. Let's see. How predictable is 4 bicuspid extraction with clear aligners? Do you routinely use any of these adjuncts in extraction cases? The answer to the last question is absolutely. How predictable? For me, not so much. It is always a struggle for me with bicuspid extraction cases, and because of the tipping moments on those teeth as the spaces are closed, it is difficult for parallelism to occur without ending up with intrusion of molars and premolars. So I am doing extraction cases. So I always warn the patients that we may end up with some braces on those particular teeth to parallel roots. How do you create the space needed between teeth prior to movement? That is critical. Some folks use lots of interproximal reduction. Some even prescribe patients to take home some types of lightning strips to do a little bit of reshaping or stripping themselves. Others will do it in the office. They may disc the teeth. You can ask for creation of space. What I prescribe when I'm doing a ClinCheck is I ask for the first step to be to open more than 0.3 millimeters of visible space adjacent to the teeth that are in question. Then either labiolingual movement or rotational movements can be done. And I always ask for those movements to be done beyond ideal or past ideal. For an example, I'd like to have a tooth that's positioned labially to be moved 0.25 millimeters past ideal to the lingual, or a rotated lateral incisor. I will ask for 2 to 3 degrees of rotation past ideal to the direction that I'm asking for it to be moved. I hope that helps a little bit. The articles that are referenced and one coming out in seminars talks a little bit more about that. Why do the vertical and horizontal pliers punch a hole in the aligner if you squeeze too hard? Well, I think you've answered your question. You squeeze too hard. It is a light force. If you're squeezing that hard, you're way overdoing this. It is a small indent. It cannot produce a huge amount of change. It is subtle over a series of those aligners. How often would you select a clear aligner to correct open bites? Any diagnostic criteria or guidelines for the same? It really depends on each patient and how I feel their cooperation would be. And if I have lots of other tooth movement that has to occur, then I may just consider sticking with braces, with mini screws, maybe even in some instances a surgical procedure. Those cases where there's not huge amounts of other tooth movement that are going to compound this problem, if it's a mild anterior open bite, I would warn the patient we're going to try to do this with the aligners. I'm going to ask for a lot of compliance on their part. We may add in mini screws and elastics. If we aren't getting what we're looking for, we may need to change gears and add in some braces. In your experience, would you please tell me what's the ideal age to use Invisalign? I was a skeptic in terms of using aligners for younger patients. I was asked by Dr. Orhan Tuncay from Temple University to participate in the Invisalign Teen Research Project. There were 4 of us involved in that prior to the introduction of that particular product in the marketplace. And I believe I had 37 of the 52 patients in the study. I was pleasantly surprised to see the compliance level and the effects of the aligners. We specifically were testing the torque ridges and found that they were effective. We also looked at compliance indicators. So I have done teens since that study started, and certainly there are patients that are non-compliant, and you have the warning to the patients at the outset and to their parents. If you choose Invisalign and we find that it's just not working out because of your lack of compliance, we know you're going to get no result if you're not wearing them. Suddenly braces will appear on your teeth. And that's sort of the threat. And we have had to do that upon occasion if the patient would like to have straight teeth. So I'm not sure that there is an ideal treatment age. I certainly believe that teenagers are great patients in most instances, and certainly are older adults. So I think it's a wide variety. Asking about mini screws with elastics, does it reduce the stability, or do I notice an increase in failures? I have not specifically noticed an increase in failures with these elastics in these particular Invisalign cases. As we know, the loss of mini screws is multifactorial. Certainly, proximity to the roots has been one of the main concerns. This is something I address in a lot of top lectures and articles I've written about mini screws. But I've been very pleased that we've had great success with mini screws. Always they're better, more stable in the palate, and also in the buccal on the upper, less so in the lower. And I think we're going to end there. I'll turn it over to you now.
We'd like to thank Dr. Bowman for an excellent program this evening, and all of you for your very active participation. We hope you identified some concepts that will be useful to you in your practice and help you to perform at your best. If you believe any of your colleagues would benefit from the information presented, a recorded version of this program will be available at hu-friedy.com/webinars. Thank you all for joining us, and we look forward to connecting with you